When surgeons in Shanghai placed a 1-year-old girl into a scanner, what appeared on the screen was not fluid. It was structure, bone, digits, and a curved spine pressed against her own. What they found inside her skull would rewrite every medical assumption about where life begins and where it fails to end. For months, something had been alive inside her brain, drawing blood from her arteries, growing silently in the dark. If you want more stories like these every day, like this video, share your thoughts in the comments below. And don't forget to subscribe to the Shadow Book for more true stories buried in the dark corners of history. The child arrived on a rainy morning. Her parents carried her wrapped in a pale blanket, her head noticeably enlarged, the eyes sluggish to follow motion. At the admitting desk of Huashan Hospital's pediatric neurology unit, the father explained that she could no longer sit upright without support. The mother added that the child had begun sleeping more than usual, sometimes for an entire day. No fever, no convulsions, only the weight of her own head. In the examination room, the attending physician measured the cranial circumference twice, 49 centimeters, well above average for her age. Reflexes were delayed, particularly the grasp and plantar responses. Pupils responded to light, but with irregular contraction. The initial impression was hydrocephalus, excess cerebrospinal fluid pressing against the skull plates. Standard procedure called for imaging confirmation before drainage. A nurse recorded vitals and secured the child to the padded table of the 64-slice Siemens CT scanner. The mother stood behind the glass, holding her own wrist. Inside the control room, the monitor displayed the first axial slice, expanded ventricles consistent with fluid retention. The next few slices appeared typical, until an area of density appeared near the left lateral ventricle. The radiologist adjusted the contrast, recalibrated, and rescanned. The dense area persisted, distinctly linear. He zoomed in, zoomed. The formation was segmented, curved, running along the parietal wall. Beneath it, smaller rounded densities aligned at intervals like jointed nodes. He increased magnification again. The resolution confirmed cortical bone density, vertebral in structure. Silence filled the room. The hum of the cooling fan and the intermittent click of the scanner were the only sounds. The radiologist repeated the scan under a different algorithm to rule out artifact. When the new image loaded, the same pattern appeared, clearer this time. A spinal column-like curve, terminating in an irregular cluster suggestive of limb formation. He printed one frame and laid it under the viewing lamp. "It isn't fluid," he said, almost to himself. "It's organized tissue." Another technician stepped closer, scanning the film from edge to edge. "Could be teratomatous," he suggested. The radiologist shook his head. "Too symmetrical." They summoned the on-call neurologist, Dr. Zhongze Li. When he entered, he examined the images without comment. He requested the contrast phase and perfusion mapping. On the screen, fine vascular threads appeared connecting the structure to the host's arterial network. Blood flow was active. Dr. Li turned toward the monitor's light reflection, tracing the outline with one gloved finger. The configuration resembled a curled fetus, vertebral line, forearm projection, digits faintly bent toward the optic tract. He requested an MRI for tissue composition, though his voice had lost its neutrality. Outside, the parents waited on the corridor bench. Through the window, they could see the silhouettes of doctors behind glass, speaking without expression. The father kept his hands clasped, the mother's gaze fixed on the floor. When Dr. Li returned, he placed the scan in an envelope without explaining. "We need further imaging," he said. "There's a structure inside your child's skull that requires confirmation." He did not call it a mass, or a growth, or a twin, only a structure. In the observation room, the radiologist kept staring at the last scan still on the monitor. The grayscale outline showed tiny, curled fingers, visible even through the static. "This is not a tumor," Dr. Li finally said. No one corrected him. The image remained illuminated, steady, clinical, undeniable. The second imaging session was scheduled 12 hours after the initial CT. The child was sedated under standard pediatric protocol, chloral hydrate dose calibrated to weight, heart rate monitored through adhesive leads. Her breathing remained steady throughout. Inside the MRI chamber, The sound of the rotating gradient coils echoed through the suite like slow mechanical percussion. On the control screen, the first high-resolution scan formed line by line, axial, coronal, sagittal. Compared to the CT, the structure was now indisputable. A defined vertebral arc occupied the left cranial cavity, displacing adjacent grey matter. Two thin projections extended forward, limb-like, ending near the ocular orbit. Bone density readings were consistent with a developing humerus and radius. The radiologist enhanced contrast and overlaid vascular mapping. A single arterial channel emerged from the middle cerebral artery, feeding directly into the structure. The blood flow was faint, but rhythmic. A secondary circulation, neither autonomous nor passive. Dr. Lee reviewed the perfusion data twice. Not necrotic, he noted, sustained by host supply. The technicians exchanged no words. Each annotation was entered with deliberate accuracy. In the reconstruction phase, the digital model rendered the structure in 3 dimensions. What appeared on the screen resembled a partially formed fetus: spine, upper limbs, traces of cranial bone, and incomplete rib alignment. The head portion faced inward, oriented toward the child's forebrain. The limbs angled forward, aligned with the host's eyes and motor cortex, their positions anatomically precise. Dr. Lee instructed that the data be archived under restricted access. "This remains undetermined," he said. "Classification pending histological review." He avoided the word fetus. The radiologist labeled the folder anomaly, intracranial organized tissue unclassified. At the observation desk, 2 junior residents whispered their doubts. One suggested a highly differentiated teratoma, another argued developmental inclusion. The senior technician ended the discussion. "Until we sequence it, speculation has no meaning." He closed the patient file and secured it with a red tag, restricted until verification. Meanwhile, the parents waited in an adjacent consultation room, unaware of the exact findings. The father asked if the swelling was due to fluid, if surgery would relieve pressure. The attending physician offered only that further tests are in progress. The mother asked if her child was in pain. No one answered directly. Back in the imaging lab, Dr. Lee reviewed the coronal slices one final time. The fetal outline appeared distinct, almost symmetrical. At one point, he paused on a scan where the upper limb projection reached forward, its fine bone shadow aligned with the host's optic nerve tract. He increased magnification, traced it again, and remained still for several seconds. He then signed the preliminary report, organized embryonic structure, showing vascular dependence on host circulation. Nature undetermined, awaiting genetic confirmation. The document was sealed. Before leaving, he turned to the radiologist. "Send samples for sequencing. We need to know if this is her or another." That night, the files were uploaded to the secure hospital server under an anonymized identifier. Only 3 authorized accounts had clearance. The folder title contained no name, only a code. HF 2022-47, Undetermined Biological Inclusion. On the final MRI slice, stored separately, the skeletal outline seemed to curve forward within the cranial cavity. The limb remained directed toward the region of vision, frozen mid-extension, as if the shape behind the child's eyes was still reaching outward from within. Dr. Lee began the review that night. The case data had already been encrypted and filed, but he accessed restricted archives through the hospital's research terminal. Using indexed medical databases, he searched for intracranial fetus in Fetu cases recorded since the 19th century. Fewer than 20 appeared. Most had been labeled anomalies, a few dismissed as teratomas, none fully explained. The earliest entry came from The Lancet, 1888, a post-mortem description of a male infant whose skull contained a malformed twin with partial limbs and fused vertebrae. The report called it an intracranial inclusion. Later studies, Lancet 1982, Indian Journal of Pediatrics 1999, Neurology 2013, documented the same pattern. Identical twins, failing to separate, one enclosing the other. In every case, the surviving host exhibited hydrocephalus, impaired coordination, and abnormal cranial expansion before discovery. He printed autopsy photographs from the Indian case. The enclosed twin S skeletal frame had extended toward the occipital lobe, pressing against neural tissue. Another report noted vascular dependence, a shared artery maintaining viability inside the host for months after birth. Each description ended with surgical extraction, followed by decline or death. At the conference table, Dr. Lee highlighted recurrent notes: vertebral curvature, cranial folding, partial limb articulation, host perfusion. The patterns were uniform across a century of study. One outlier in 1975 included a parent S statement claiming the infant appeared to respond to unseen movement. The notation was crossed out in red ink during peer review. In the following days, Lee requested institutional clearance to correlate historical EEG data from older records. A pattern of low-frequency neural interference appeared in several, though each was later dismissed as electrode artifact. Still, the identical readings, irregular internal rhythms synchronized with the host's pulse, remained consistent across cases. During the next consultation, the parents were shown only selected images. The father asked if such cases had occurred before. Lee replied that similar conditions had been documented but rarely survived. The mother's next question was quieter. Could she hear it? Lee looked at the floor before answering. No. There are no sensory pathways, it's only tissue. In the laboratory, 2 residents compiled the research summary. They listed 18 global cases, each confirming incomplete twinning during early blastocyst division. Common outcomes: vascular attachment, partial development, fatal compression. The term fetus in Fetu appeared only after 1935, replacing the older embryoma and parasitic twin. Modern classification under neurology defined it as a developmental inclusion of identical genetic origin. Lee added a private note to the file. Pattern persistence suggests unrecorded cases remain undetected due to location or termination before viability. He stopped typing for several minutes before saving. Later that evening, the hospital director requested a briefing for publication consideration. Lee agreed, but recommended anonymity for both patient and parents. "The public will not understand," he said. "This is not a deformity. It's a process that never completed." The printed records were placed in a grey folder marked Historical Comparative Review, Intracranial Developmental Inclusion. He closed it, paused, then added one final line to the abstract. All previous subjects exhibited internal motion detectable before diagnosis, interpreted as vascular pulse or neural echo. He hesitated before turning off the screen. On it remained the scanned image of the current patient, the faint outline of 2 limbs extended toward the optic cavity. For the first time, the repetition across centuries did not feel statistical. Pre-operative mapping began at 0740 hours under sterile protocol. The child was anesthetized and connected to dual monitoring: intracranial pressure transducer, arterial line, pulse oximetry. The team's objective was to isolate vascular flow to the intracranial mass before surgical removal. Digital subtraction angiography displayed a single arterial conduit branching from the left middle cerebral artery. The vessel extended directly into the encapsulated structure, entering at the midline and dispersing through smaller tributaries. Dr. Lee recorded continuous flow, a clear indicator that the parasitic tissue drew blood from its host. The discovery reframed the case. Survival of one depended on the other. Neurosurgeons from 2 departments convened around the projection monitor. One suggested embolization, occluding the vessel with microcoils to starve the tissue. Another warned that any abrupt cutoff could trigger ischemic injury to the host cortex. Every option risked irreversible harm. In the operating theater, the patient's heart rate remained steady at 122 beats per minute. As angiography contrast pulsed through her vessels, the monitor displayed an anomaly: 2 rhythms, slightly offset, alternating between peaks. One matched the host's cardiac output, the other mirrored perfusion inside the mass. The patterns synchronized, then separated again, a dual signal emerging from a single system. Dr. Lee watched the graph in silence. "We're seeing cross-feedback," he said. "Both circulations are reacting." The anesthetist verified equipment function. No error. The rhythm persisted. It was not artifact. Further imaging confirmed the fetal mass possessed microcapillaries responsive to oxygen saturation changes, though without any autonomous heartbeat. Instead, it moved in synchrony with the child's systemic flow, a parasitic reflex embedded within neural tissue. The surgeons debated intervention timelines. If blood flow was reduced gradually, necrosis might occur without cerebral compromise. But if the tissue remained viable too long, it could continue expanding within the confined cranial cavity, worsening pressure. They set a temporary plan: maintain perfusion for 48 more hours while constructing a 3D vascular model for simulation. At the bedside, nurses monitored cerebral pressure and oxygen levels. The readings fluctuated between mild elevation and transient dips, stabilizing only when both pulse traces aligned. Every deviation corresponded to the secondary pattern's lag. That evening, the ethics committee convened. The chairman summarized the dilemma. Any interruption risks termination of the host. Continuing circulation sustains a non-viable organism. Lee proposed a staged approach: partial occlusion followed by surgical resection if stability held. Consent forms were drafted in neutral phrasing. When the parents arrived, Dr. Lee explained only that a vessel was feeding the abnormal growth. "Cutting it too quickly," he said, "might cause damage. We will proceed carefully." The father asked, "If you stop it, will she survive?" Lee replied after a pause, "We believe so." He did not elaborate on the uncertainty embedded in the data. As the parents signed, the monitors behind the glass displayed the paired rhythms again: one large pulse, one faint echo. Both persisted at near-perfect intervals, a mechanical duet without deviation. Before leaving the room, Lee spoke quietly to the surgical registrar. "If one stops," he said, watching the synchronized lines on the screen, "so will the other." The next day's operation was deferred. The mass continued to draw blood through shared vessels, two dependent lives sustained by the same circulation, neither fully separate, neither capable of existing alone. The procedure commenced at 0610 under full aseptic protocol. The patient was intubated and anesthetized with sevoflurane, fentanyl, and vecuronium. Monitors displayed steady vitals: heart rate 118, oxygen saturation 99%. 3 cameras documented the surgery for internal record: one at the overhead rail, one at the left shoulder, and one fixed on the surgical field. Dr. Lee led the team of 4 neurosurgeons. A linear incision was made along the left parietal region, followed by retraction of scalp and periosteum. Under the surgical light, the cranial bone appeared thinned from pressure. A powered drill outlined the craniotomy site. Suction cleared irrigation fluid as bone dust mixed with saline on the sterile drape. The skull plate lifted with a faint crack. At once, the exposed dura bulged outward under intracranial pressure. Lee signaled for drainage. As the vented fluid subsided, the membrane S surface revealed irregular discoloration, small red capillary strands intersecting in patterns inconsistent with normal vasculature. Cauterization exposed a fibrous membrane beneath, resembling placental tissue in tone and texture. On the third night, the mother again reported hearing faint pulses through the monitor. Not as sound this time, but as vibration in the mattress, subtle enough to question perception. The nurse checked the bed's pressure sensors. Nothing registered. The patient slept with eyelids trembling in rapid movement, as if in REM phase. By morning, the EEG displayed another synchronized event: 2 rhythmic surges aligning in perfect sequence, identical to the recorded fetal pulse rate from angiography. One technician remarked, "The rhythm matches." Lee instructed him not to include commentary in the report. "List data only," he said. Later that day, to rule out interference, the monitoring system was temporarily unplugged. The EEG device remained offline for 12 minutes. When power was restored, the saved buffer displayed a continuous trace, uninterrupted recording throughout the disconnection period. The redundant signal had persisted, even without active input. Lee reviewed the data privately. He replayed the final minute before shutdown. The twin waveforms converged, their intervals tightening until they overlapped entirely. One trace superimposed over the other. He watched the pattern repeat 3 times before stopping the playback. The official summary recorded, "Possible equipment error." No one contested the classification. The child's vitals remained stable, her movements improving daily. Still, each night, the mother requested that the monitor remain muted. She said it was easier to rest when she couldn't hear the machine's pulse. The review board assembled on a Friday morning in the hospital's conference room. Attendance was restricted, 6 physicians, 1 ethics advisor, and a recording secretary. The meeting agenda was labeled confidential. Case HF 2022-47. The blinds were drawn, no external observers were permitted. Dr. Lee opened with a concise summary of surgical events: patient stable, anomaly removed, post-operative recovery satisfactory. He presented no images, only text and vital charts. Each member received a printed dossier marked internal circulation only. The first page defined the extracted specimen as intracranial fetus in fetu, a developmental inclusion derived from incomplete monozygotic division. The board's purpose was not to reassess medicine, but to prepare language suitable for publication and internal archive. The committee chair reminded everyone that external release required strict anonymization, no family identifiers, no post-operative EEG data, and no subjective descriptions. "This will be a clinical record," she said, "not an interpretation." Lee outlined the sequence from diagnosis to extraction: discovery by CT, confirmation by MRI, observed vascular dependence, surgical removal at 06:47, termination of circulation by 07:12. Each detail was read aloud from the operative log. The members followed silently, turning pages in unison. When discussion opened, the pathology report drew attention. The specimen's perfusion data indicated continued oxygenation for 47 seconds post-extraction, recorded through microcapillary sensors before collapse. The notation read, "Residual perfusion detected following detachment, fading at 47 seconds. One surgeon raised the question of viability. Could it be reflex perfusion? Another replied, "Capillary momentum can't sustain for nearly a minute." Lee interjected quietly, "There was no cardiac source. The flow was systemic. Once detached, it should have ceased immediately." The chair asked for clarification. Was there measurable cardiac activity? Lee shook his head. "No, only perfusion." The room fell silent. The recording secretary typed steadily, noting only discussion on residual oxygenation. After several moments, the ethics advisor spoke. "If we define viability by function, not by flow, then 47 seconds is mechanical persistence, not survival." Another surgeon added, "Then call it reflex." Lee said nothing. He reviewed the printed graph in front of him, a sloping line that flattened at 47.2 seconds, recorded by the microprobe inside the vessel. The shape resembled a fading pulse. The board voted to classify the event as non-viable post-detachment tissue response. The phrase "oxygenated for 47 seconds" remained in the internal file, but was excluded from the publication draft. Additional redactions removed mention of post-operative dual EEG signals, maternal auditory reports, and specimen photography. The final report, addressed to the editorial office of neurology, comprised 6 pages. The closing statement read, "Case represents rare occurrence of intracranial fetus in fetu. Surgical outcome favorable. No evidence of independent viability." It bore the signatures of Lee and 2 department heads. After the meeting adjourned, the members filed out without conversation. The secretary closed the laptop, labeling the transcript restricted. Lee remained alone at the table for several minutes, reviewing his handwritten notes. On one page beneath the official conclusion, he had written in pencil, "Perfusion maintained 47 seconds after isolation. Reflex unproven." Later that evening, a copy of the draft circulated to the hospital's archive server. At the bottom of the metadata record, the system automatically added a timestamp, 07:59:47. Data file closed. No one mentioned that the time matched the final second of recorded perfusion. 6 months after the operation, the child returned for evaluation. Her gait remained unsteady, but she could stand with assistance. Speech had not developed beyond fragmented syllables. Cognitive assessment was deferred. The parents were instructed to continue daily physiotherapy and report any episodes of seizure or prolonged sleep. Routine follow-up imaging was scheduled, MRI with calcium mapping and diffusion-weighted sequences to assess post-surgical healing. The child was sedated lightly and positioned within the scanner. The initial slices showed normal ventricular size, indicating stable intracranial pressure. The surgical cavity had contracted and sealed with glial scarring. Then the technician noted faint radiodense spots along the cavity's interior margin. Magnification revealed multiple microcalcifications aligned in a curved pattern. Each was less than 2 millimeters in diameter. Their shape was irregular, yet several displayed the elongated structure of phalangeal bone. The finding was unexpected. Post-operative ossification was uncommon in such confined neural space. The report was forwarded to Dr. Li. He examined the reconstructed images on the workstation. The calcifications followed a shallow arc parallel to the visual cortex, precisely where the fetal limb had once rested. He instructed the technician to confirm artifact exclusion by adjusting gradient field parameters. The deposits persisted. Residual bone fragments, the radiologist suggested. Probably calcified membranes. Li nodded without reply. He noted the distribution and density in the record. 5 to 7 ossified nodes, stable perfusion, no edema. He did not include their shape in the summary. The parents were informed that healing was satisfactory. The mother asked about the white marks she saw on the printed film. Li answered that they were post-operative deposits, with no risk of growth. She hesitated before asking, "Can they grow again?" "Not anymore," Li said. His tone remained neutral, but the wording lingered. The follow-up committee recommended monitoring every 6 months. The scans would be repeated under identical parameters to track structural changes. No one explained why the interval was indefinite. In the evenings, the mother kept the child's rehabilitation log by hand. She wrote that the girl sometimes turned her head abruptly toward light sources, as if startled by movement no one else could see. The therapist attributed it to visual recovery. Li read the note during review and filed it without comment. In the imaging archive, the calcifications appeared sharper with each digital enhancement. Under specific lighting, the aligned nodes resembled a small skeletal outline. The software automatically mapped their positions and labeled them region of interest, posterior occipital tract. Li printed one image and stored it in his private folder. The hospital's digital log now contained 3 entries under HF 2022-47, longitudinal observation. The closing line read, "Residual ossified material consistent with microcalcification. No further intervention recommended." Before shutting down the workstation, Li opened the final image again. The arc of fragments traced the contour of a tiny hand, fingers extending toward the cortical edge. He marked the case as stable and closed the file. The next review was scheduled for June, and every 6 months after, without stated end date. The publication appeared on December 12, 2022, in Neurology, Volume 99, Issue 24. The article was brief, 6 pages, 10 figures, 1 table. Its title read, "Intracranial Fetus in Fetu in a 1-year-old Female, Surgical and Genetic Correlation." The authors listed included Zid Li et al., Department of Neurology, Fudan University. The patient's name did not appear. The introduction summarized, "A rare developmental anomaly, citing fewer than 20 documented intracranial cases worldwide." Methods and results occupied most of the text: imaging, surgical approach, genetic sequencing, outcome. The tone was factual, uniform, without speculation. Every personal reference had been removed during editorial review. The final paragraph stated, "The excised tissue demonstrated complete genetic identity to the host, confirming non-viable embryonic inclusion consistent with fetus in fetu." Within the hospital, the physical report was filed under catalogue number F2022-HF. The preserved specimen, sealed in formalin, was transferred to the Department of Developmental Pathology and stored on shelf 4C with other congenital samples. The entry read, "Specimen retained for research reference. No further testing authorized. The child's ongoing rehabilitation records were maintained separately under a new identifier to prevent traceability. The publication drew brief attention in medical news outlets. Headlines called it "A Miracle of Modern Surgery" and "The Baby Born with Her Twin Inside Her Brain." No outlet mentioned the family or the details of post-operative monitoring. Public fascination focused on survival, not the implications. In his office, Dr. Lee received a printed copy of the journal issue. He annotated the margins with corrections the editors had declined: missing vascular data, omitted perfusion note. At the last figure, a CT reconstruction, he paused. The image showed the fetal outline in grayscale, curled inside the cranial cavity. Its right arm extended toward the host's orbit, fingers half bent. The original surgical team had debated whether the position was natural or due to pressure deformation. The caption simply read, "Pre-operative axial scan demonstrating organized inclusion." Lee placed a bookmark there and closed the journal. Later, he opened his private archive folder on the secured drive. Inside was the unedited CT sequence taken before contrast enhancement. Frame 27, timestamp 06:43:11. The same arm appeared, raised higher than in the published version, angled toward the optic cavity, as if positioned deliberately before fixation. He copied the image to a separate encrypted file and renamed it "One Heart, Two Beginnings," JPG. Then he deleted the metadata. At 22:15, the hospital's archival system logged the case as closed. The automated summary listed final outcomes: patient stable, no recurrence, specimen preserved. The record contained no mention of EEG residue, calcifications, or the 47-second perfusion anomaly. Before leaving for the night, Lee wrote a final line in his personal notebook: "One heart, two beginnings." He replaced the book in the drawer and turned off the office light. In the dark, the screensaver on his computer still displayed the paused CT frame. The fetal arm remained lifted, fingers half curved toward the light source. Whether the motion had been defensive or reflexive could not be determined. The monitor's glow dimmed automatically after 60 seconds, leaving the image unrecorded but intact.